Hi, my name is Neetu Radhakrishnan. I'm Associate Professor at University of Cincinnati. I want to thank the organizers for allowing me to be part of this Best of ASCO. Let me share my screen. So I was asked to talk about recent advances in breast cancer, and most of it is from the Best of ASCO. Um, First, we'll talk about adjuvant therapies. The first trial that I wanted to talk about was the neoadjuvant endocrine treatment approach called the alternate trial that was presented by Dr. Cynthia Ma. This was a trial that included only postmenopausal women in hormone receptor positive HER2 negative disease. And she chose to randomize them in a neoadjuvant fashion to anastrozole, fulvestrant, or um, anastrozole plus fulvestrant, and she chose to the group chose to look at something called a modified PEPI score, which is a preoperative endocrine prognostic index score that includes the pathological tumor size, nodal status, Ki67 level, and ER status after neoadjuvant endocrine therapy. They also had a modified PEPI score, and they sought to validate this score as a surrogate endpoint for relapse-free survival in this setting. The bottom line in this trial was that it showed that there was no benefit, no difference in benefit from anastrozole versus fulvestrant versus the combination of the two, and that the endocrine sensitive disease rate remained the same in roughly in the 18 to 20% range, with no significant difference between the three arms, going to show that it is perfectly reasonable to give an oral pill such as anastrozole in place of a shot such as fulvestrant in the neoadjuvant endocrine setting, uh, um, um, and get reasonable responses. The next trial that I wanted to talk about was the MINDACT trial that looked at the long-term results of the 70 gene signature mammoprint as guidance for adjuvant chemotherapy in hormone-positive breast cancer patients. This was a de-escalation study, and what it had shown in 2016 was that in the group that were clinically high risk but genomically low risk, it was okay to go without chemotherapy, and they had very good disease distant metastasis-free survival at 5 years. The update to this study was presented at ASCO recently, where they looked at the effect of chemotherapy by age in the hormone positive HER2 negative subgroup of the genomically low group, similar to the Taylor RX trial. It appears that in the less than 50 years age group, there is a difference in distant metastasis-free survival between the chemotherapy group versus the no chemotherapy group, in the range of about 2.6 to 3% roughly at 5 years. But this difference increased to about 8 years. Increased to about 5 years at the 8-year mark. However, in the greater than 50 years age group, there was no significant difference between the chemo and no chemo arms. The take-home point from this would be that in the premenopausal women, the difference seen might be clinically relevant, and that one should consider the effect that chemotherapy brings about to induce ovarian function suppression in the premenopausal woman. Therefore, omitting chemotherapy in the clinically high, genomic low postmenopausal woman continues to be safe, but in the premenopausal woman, the algorithm for treatment might need to be changed, in that if they're clinically high risk premenopausal and the mammoprint comes back low, despite that, one should consider or discuss with the patient the benefits of ovarian function suppression versus chemotherapy. In the MINDAC trial, most of the patients had only received tamoxifen for endocrine suppression. They did not receive ovarian ablation. And as we know from the soft and text data, there is a benefit for ovarian suppression in the range of 5 to 8%, especially in the premenopausal group. The next study that I wanted to talk about was the TRAIN-2 study, which was a study from Netherlands looking at the 3-year data of neoadjuvant chemotherapy with or without anthracyclines in dual HER2 blockade for HER2 positive breast cancer. In the United States, we have generally moved away from anthracycline-based chemotherapy, and most treatment includes trastuzumab, taxane, and carboplatin for 6 cycles. This study looked at the difference between an anthracycline for 3 cycles, followed by taxane, trastuzumab, and carboplatin for 6 cycles, versus 9 cycles of taxane, trastuzumab, and carboplatin plus pertuzumab in both the arms, of course. The endpoint of the study was pathological CR, and the secondary endpoint was toxicity. The study showed that there was no benefit in event-free survival or overall survival in the anthracycline-containing regimen when compared to the non-anthracycline-containing regimen. There was no evidence that higher-risk HER2-positive breast cancer patients require anthracyclines, and the addition of anthracycline increases the risk of febrile neutropenia, cardiac toxicity, and the risk of AML. Therefore, it is better to de-escalate chemotherapy in the HER2 positive patients and reduce the use of anthracyclines, probably. The next study in the HER2 setting was the Caitlin study that sought to see whether replacing trastuzumab and pertuzumab plus taxane in the adjuvant setting with trastuzumab, emtansine, or TDM1 plus pertuzumab may be better for the high-risk HER2 positive breast cancer patients. They defined early breast cancer, which was high risk, as either node positive or node negative and hormone negative and tumor greater than 2 centimeters. In this trial, they were randomized to either the TDM1 arm versus the no TDM1 but trastuzumab arm. They did get anthracyclines because this was a study that was conducted in many parts of the world. And the study showed that there was no benefit to the addition of TDM1 in the adjuvant setting in place of trastuzumab. The lines were pretty much equal and same all throughout. They followed each other. This is another study showing that there is no clear benefit. I'm sorry. This study showed that there is no benefit to adding TDM1 in the adjuvant setting, and adjuvant trastuzumab, pertuzumab, and chemotherapy remains a standard of care for patients with high-risk HER2-positive early breast cancer. The ASCO 2020 also had an update on biomarker data from the Catherine study, which was a study of adjuvant TDM1 versus trastuzumab in patients with residual invasive disease after neoadjuvant chemotherapy in the HER2-positive breast cancer. As you know, in 2019, the study showed that there was a significant benefit in 3-year invasive disease-free survival in the range of about 11% in those who were switched to TDM1 from trastuzumab when they had residual disease after neoadjuvant chemotherapy. They looked at various biomarkers and genomic markers, and there was no clear signal except for the fact that in the group, in those patients who had residual disease and who had high versus low HER2, the patients who had a high HER2 residual disease tumor seemed to do worse with trastuzumab as compared to TDM1. And this might be one of the mechanisms whereby maybe they do develop resistance to trastuzumab because of a high HER2 expression. In the triple-negative breast cancer setting, there was another trial showing a benefit for capecitabine in the maintenance setting. This was a trial from South China, that shows high-risk triple-negative breast cancer patients who were stage 1B to 3C, ER negative, PR negative, HER2 negative, and they randomized them after standard treatment to 650 milligrams per meter square continuously for 1 year of capecitabine maintenance. The study showed that there was an improvement in disease-free survival of about 10% from 73% to 83% in the capecitabine group, and the overall survival at 5 years was improved by about 5% from 81 to 86%, consistent with some previous trials. Therefore, it appears that this is another way to improve disease-free survival in this high-risk triple-negative breast cancer group with maintenance therapy with a lower dose but metronomic capecitabine for 1 year. Safety profiles were well tolerated. There were no serious adverse events. The NSABP B43 trial was a trial looking at the benefit of trastuzumab in the adjuvant setting given for 2 doses in those who had DCIS and who were also getting radiation concurrently. The trial failed to show any benefit to adjuvant trastuzumab for DCIS. So future studies might need to focus on higher risk groups such as hormone receptor negative, high grade HER2 positive DCIS. Moving on to the metastatic breast cancer setting, the first trial to talk about would be the ECOG Akron 2108 that looked at the benefit of local regional therapy in de novo stage 4 breast cancer patients. As we know, there has been conflicting data. The Tata study showed no benefit, whereas the Turkish study showed some benefit to local regional therapy in this group of de novo metastatic breast cancer patients. In this trial, they chose patients who had been on treatment for at least 4 to 8 months and had no signs of disease progression, and can either randomize them to continued systemic therapy versus early local therapy and followed them for 5 years. The study showed no clear benefit to local regional therapy in any subgroups, triple negative, hormone positive, or HER2 positive disease. And in fact, there was a trend towards worsened survival in the triple negative breast group. Moving on to immunotherapy, which is the keyword nowadays, the Keynote 355 pembrolizumab plus chemotherapy for first-line metastatic triple-negative breast cancer trial randomized metastatic triple-negative breast cancer to pembro plus chemotherapy versus chemotherapy alone. And they tried to stratify based on the CPS score of greater than 1 or less than 1, chemotherapy given, and prior treatment. Overall, the study was not able to show a significant benefit in the entire population, but there was a benefit with a significant p-value in the group that had a PDL1 combined positive score of greater than 10%, with a difference in disease-free survival of 5.6 months versus 9.7 months. So my takeaway from this study was that while pembrolizumab may be beneficial in some triple-negative breast cancer patients with a CPS score of greater than 10, one has to carefully decide which patient population to choose. So it does come with about 10 to 15% grade 3 to 5 toxicity, and there is the cost of financial toxicity associated with it too. Another drug in the market that was recently approved in April was sacituzumab govitecan HZIY for metastatic triple-negative breast cancer. This was based on the IMMU trial, which was a multi-center single-arm trial that enrolled 108 patients. All these patients had at least 2 prior therapies for metastatic breast cancer. Overall response was 33.3%, and median duration of response in this group of patients who have been multiply treated was a very decent 7.7 months. The drug is given at 10 milligrams per kilogram IV on days 1 and 8 every 21 days. In the hormone-positive metastatic breast cancer, The Parsifal trial tried to answer the question as to whether combining a CDK4/6 inhibitor with fulvestrant would be better than an AI in the metastatic breast cancer setting. So they chose postmenopausal women, and this was because in the first line metastatic breast cancer hormone positive setting, fulvestrant was shown to have an improved median progression free survival of 16.6 months versus 13.8 months in the past. So the question was, would this apply to when combined with the CDK4/6 inhibitor? Unfortunately, the trial did not show any significant benefit to the addition of fulvestrant versus an AI when combined with a CDK4/6 inhibitor. In fact, there was a slight trend towards the aromatase inhibitor arm doing better. And this might be because in this trial, only about 40% of patients had ever seen endocrine therapy, and only about 25% of the patients had seen an aromatase inhibitor. And and as we know, ESR1 mutations contribute to aromatase inhibitor resistance, which is the scenario in which fulvestrant seems to help more. And this is consistent with the forest plot that showed that there was a trend towards benefit in the fulvestrant arm if they had seen prior AI, but the trend was lost when they had not seen a prior AI. In keeping with this line of thought was the PADA trial that looked at ESR1 mutations in metastatic breast cancer first line who were treated with an AI and palbo, and they were randomized to AI plus palbo versus fulvestrant plus palbociclib. The study showed that the presence of an ESR1 wild type mutation was beneficial. ESR1 mutant patients did relatively poorly with a progression-free survival of 11 months versus 26.7 months. However, the analysis also showed that adding a CDK4/6 inhibitor helped reduce the incidence of ESR1 mutations in these patients by up to 2/3. That is, the ESR1 mutations disappeared in up to 2/3 of the patients. Another study that was relevant was the alpelisib plus fulvestrant study in patients with PIK3CA mutant hormone receptor positive patients. Alpelisib was approved in the United States about 2 years ago for PIK3CA mutant patients in combination with an aromatase inhibitor. This study showed that there was benefit to doing alpelisib plus fulvestrant in those who had even had prior CDK4/6 plus AI as first-line therapy, and this would be the second-line therapy. The primary endpoint for the prior CDK inhibitor plus AI cohort was met, with 50.4% of patients alive without disease progression at 6 months, and the secondary endpoint of median progression-free survival of 7.3 months. So to summarize, in the first line setting without prior AI exposure, CDK4/6 inhibitor plus AI or fulvestrant were equally efficacious. ESR mutations are bad with AI therapy. However, dual therapy with a CDK4/6 inhibitor plus AI appears to clear these mutations in 2/3 of patients. And in those who have seen first-line CDK4/6 inhibitor, alpelisib plus fulvestrant is effective in the second line. In the HER2-positive disease with brain mets, the most important study was the tucatinib HER2 CLIMB study. As we know, brain mets are very common in those who have HER2-positive breast cancer, up to 50% incidence. The HER2 CLIMB study design was very interesting in that they decided to include patients who had stable brain mets, untreated brain mets, and previously treated progressing brain mets. And they randomized them to capecitabine plus trastuzumab plus or minus tucatinib. The study showed that there was an improvement in overall survival in the brain mets group, overall survival benefit in the active brain mets group, improvement in median overall survival, and a reduction in the risk of death by 51% in patients with active brain mets. Therefore, it improved all survival parameters as a whole, and the hazard ratio was highly significant. And it grows to show that broadening eligibility criteria is a win in many cases. To summarize, in the adjuvant setting for the hormone positive patient, neoadjuvant AI is as good as AI plus fulvestrant or fulvestrant. The MINDAC study showed that in the less than 50-year luminal genomic low risk mammoprint patient, one should consider either ovarian function suppression or chemotherapy in order to improve on their disease-free survival. In the HER2 positive patients, trastuzumab plus pertuzumab plus chemo is still better than TDM1 plus pertuzumab. High risk HER2 genomic changes were seen in the residual tumor in those who in the Catherine trial, and this may be the group that may benefit most from switching to adjuvant TDM1. There is no clear role for anthracyclines in the adjuvant HER2 positive setting. Triple negative breast cancer, adjuvant metronomic capecitabine seems to improve disease-free survival by about 10%. And there is no role for DCI for adjuvant trastuzumab in the high HER2 DCIS situation. In the metastatic setting, in the first line, aromatase inhibitors plus palbociclib is equivalent to fulvestrant plus palbociclib. That's an error there in the slide. Alpencilib plus fulvestrant in the second line has activity that is reasonable. ESR1 mutations predict poor AI response, but CDK4/6 inhibitors seem to reduce these ESR1 mutations with treatment. In the HER2 positive metastatic setting, tucatinib improves overall survival, disease-free survival in the main brain mets group and in those with active brain mets by remarkable hazard ratios. The next question to answer would be, how would we sequence neratinib, lapatinib, DS8201 or TDM1 in the metastatic HER2 positive breast cancer setting? Pembrolizumab does show some benefit in the triple negative metastatic breast cancer setting in patients with a CPS score of greater than 10. And there is no role for locoregional therapy for de novo metastatic disease. And in fact, it may worsen outcomes in the triple negative breast cancer group. Thank you.